All right, future nurses, welcome. If you are getting ready for your L&D rotation or, just cramming for the NCLEX, you are in the perfect spot. Today, we're jumping into a super high-yield, no-fluff clinical explainer all about nursing care during labor. Let's get right into it.
So, first things first, let's start with a really foundational question. When you walk into that labor room, who exactly is your client? I know it sounds almost too simple, but believe me, the answer to this question defines literally everything you're about to do.
And here's the trick. You actually have 3 clients all at the same time. You've got the fetus, and your focus there is all about well-being and oxygenation. Then you've got the mother, where you're managing her physical status and, of course, her pain. And finally, you have the family unit, who needs that crucial emotional and cultural support. Every single action you take is a balancing act between the needs of all 3.
So here's our game plan for today's little clinical rotation. We're going to start at the beginning, figuring out what real labor looks like. Then we'll journey through that long first stage, get into the pain management playbook, and cover the final stages of birth itself. We'll also touch on some key procedures and potential complications, and then we'll wrap it all up with a fast-paced NCLEX review to make sure it all sticks.
Okay, Section 1, the starting line. So, your first big job as a nurse is often just figuring out, is this the real deal? Is your patient actually in labor? So, how do we spot those key signs?
Well, the body gives us a bunch of clues that it's getting ready. We call these the premonitory signs. You've got lightning, which is when the baby's head drops down into the pelvis. Your patient might suddenly say, hey, I can breathe again. Then there's that famous burst of energy, the nesting instinct. You might see a bloody show as the mucus plug comes out. Braxton Hicks contractions can get a lot stronger. And most importantly, the cervix itself starts to soften and ripen. And of course, her water might break, what we call rupture of membranes.
Now, this slide is huge for patient education. How do we tell true labor from false labor? In false labor, the contractions are all over the place, and they often just stop if she drinks some water or changes position. But true labor? Oh, true labor contractions get stronger, closer together, and more regular. Walking actually makes them more intense. But here it is, the absolute #1 most important difference. True labor causes progressive cervical change, dilation, and effacement. Without that cervical change, it's not the real thing. That's the whole ballgame.
And speaking of things being the real deal, this is a massive, massive safety alert for your exams and for real life. If a patient's water breaks, what is the very first thing you do? It's not checking the fluid color, it's not getting her a fresh gown. Your first action immediately is to check that fetal heart rate. Why? Because once that cushion of amniotic fluid is gone, the umbilical cord can slip down and get squished, totally cutting off the baby's oxygen supply. It is a true drop-everything emergency.
Okay, moving on to Section 2, the first stage journey. This is the marathon of labor, not the sprint. It takes the client all the way from those first regular contractions to being fully dilated at 10 centimeters.
We basically break this long stage down into 2 main phases. Think of it like a story in 2 parts. First, you have the latent phase, from 0 to 5 centimeters. Mom is often pretty calm. She's chatty. This is your golden hour for teaching. But then things shift. In the active phase, from 6 to 10 centimeters, everything ramps up. She gets serious. She's focused inward, and she needs your constant hands-on support. Your role totally flips from educator to coach.
And as you can see here, our nursing care ramps up right along with it. It just makes sense, right? In that early, latent phase, we might check on our vitals every 30 to 60 minutes. But once she hits that active phase, we're in there checking on mom and baby way more often, every 15 to 30 minutes, because the physical demands on both of them are so much higher.
Which leads us perfectly into Section 3, the pain management playbook. This is such a huge part of your job, and it's a really delicate balancing act. Our goal is to give mom effective pain relief while making absolutely sure the fetus stays safe.
The good news is we've got a whole toolkit of options, and you always want to start with the non-pharmacologic stuff. Counterpressure on her lower back, getting her in the shower or tub, changing positions. These things work wonders. If we need meds, sedatives are only for that very early latent phase, just to help her rest. IV opioids can be a good option in active labor, but you have to be super careful with the timing because you don't want the baby to be born with respiratory depression. And then, of course, we've got the heavy hitters, regional anesthesia like epidurals and spinals.
Now listen up, because this is so important. When we talk about an epidural, the #1 word that should pop into your head is safety. The biggest risk, by far, is maternal hypotension, a sudden drop in mom's blood pressure which can make the baby's heart rate drop. So what's our #1 way to prevent that?
an IV fluid bolus before the procedure even begins. Not during, not after, before. Then we help her get positioned, monitor everyone closely, and keep her tilted to her side to keep that blood flowing to the placenta.
All right, Section 4, birth, the final stages. We've made it to 10 centimeters. This is the main event, right? Well, yes, but it's also the lead-up to the most critical recovery period.
So the second stage is from full dilation until the baby's born, that's pushing. The third stage is from the baby's birth until the placenta is delivered. But you need to pay really close attention here. The fourth stage, those first 2 hours after birth, is probably the most dangerous part of the whole process. This is the absolute highest risk period for postpartum hemorrhage.
And I want you to burn this number into your brain. If a brand new mom soaks a perineal pad in 15 minutes or less, that is a 5-alarm fire. That is not normal bleeding. That's a massive red flag for hemorrhage, and you have to act immediately.
So, let's say that alarm bell is going off. You see that heavy bleeding, you put your hand on her abdomen, and the fundus, the top of the uterus, feels soft and boggy. What do? Your first line, life-saving, absolute #1 intervention is to start a firm fundal massage. You're literally helping that uterus clamp down and stop the bleeding. It is a simple skill that saves lives every single day.
Okay, Section 5. You know, labor doesn't always read the textbook. Things happen, so we need to be ready to recognize and respond to those challenges when they pop up.
A prolapsed cord is one of those true heart-stopping emergencies. If you see or feel that umbilical cord, you yell for help, but you do not leave that room. Your immediate job is to put on a sterile glove, reach in, and physically lift the baby's head up off the cord to restore blood flow. And you will hold that position in the bed, on the stretcher, all the way to the OR until that baby is safely delivered.
Here's another common complication, especially with inductions: uterine tachysystole. Basically, it means the contractions are coming too fast, too strong, or lasting too long. Think about it. The baby needs that rest period between contractions to get oxygen. If there's no rest, there's no oxygen. So what's your response? First things first, turn off the gas pedal. If oxytocin is running, you stop it. Then, turn the patient on her side, give her an IV fluid bolus, and put on some oxygen.
All right, we've made it to the final section. Let's do a quick hitter review of the absolute must-know, non-negotiable facts for your exam. You ready?
Let's say it one more time. Contractions by themselves don't mean it's go time. The single most reliable sign of true labor, the one thing that cannot fool you, is progressive changes to the cervix, dilation, and effacement. Period.
And when you hear the word epidural, I want your brain to immediately think hypotension. But more than that, I want you to think prevention. And the key to prevention is that IV fluid bolus before anesthesia ever walks into the room.
And I'm going to leave you with this final thought to chew on. In any crisis in L&D, whether it's a prolapsed cord or a postpartum hemorrhage, your brain is constantly making a split-second calculation: which action best protects fetal oxygenation and which action best ensures maternal safety. Learning how to prioritize between your two main clients in a crisis, that right there is the very heart of being a great labor and delivery nurse. Thanks for joining me for this explainer.